Welcome back, everyone. I hope everyone had a good lunch, even though it might have been a little bit late and you feel a little bit fortified. And some of you might have done a tour of the place and saw the three components that we have here: treatment, education, and research. And if you want to follow up any of that, you can more than welcome to follow up with anybody today or sometime in the future. I'm Bosco Rowland. I'm a statistician and a senior research fellow here at Turning Point and the Eastern Health Clinical School. I'm chairing this session on big data or data for impact. It's one of those topics that are becoming more and more important as we manage data. We've got data, we're overwhelmed with data. Data is just filling our lives. And how do we deal with the amounts of data that we've got and the systematizing and trying to find ways that can tell stories and meaningful narratives out of them. So today we've got a number of people trying to show us how Turning Point is using big data to impact and talk to the treatment and the drug and alcohol sector. So before I begin, let's begin again by acknowledging the country and the land that we stand on. Here in Richmond, we acknowledge the Wurundjeri people of the Kulin Nation as the first peoples and traditional owners and custodians of the lands and the waterways on which we gather today. We honour and pay our respects to elders past, present and emerging. Now, before I introduce the first speaker of the day or the afternoon, just to remind you that vote on your favourite presentation using the QR code. So you can get it up now if you want and have your finger hot ready to press it at the end, or it'll come up again at the end. So our first presentation today is Dr. Rowan O'Geil. He will be talking about the complexity in alcohol-related ambulance attendances, the role of Corbyn mental health, suicide, self-harm presentations during the COVID-19 lockdowns. Welcome, Rowan.
Thank you very much, Bosco, for the introduction. I'm delighted to lead the panel on data this afternoon, and I just want to say for all the qualitative researchers in the audience, please don't be scared. I'm going to tell a nice story. So alcohol is associated with significant harm to individuals, their families, communities, and ultimately the health system. And despite decreases in alcohol use measured by per capita consumption over the last couple of decades, 1 in 4 Australians still exceed risky drinking guidelines. Alcohol is associated with a significant burden of disease, as we've heard through this morning's session. Hence, there's a need to examine harms associated with alcohol use. And we can see here in the bottom graphic on this particular slide that alcohol has remained a significant contributor to burden disease over the last decade of measurement. Despite this, there's really limited population-level surveillance systems that can assess alcohol-related harms. One that can is the National Ambulance Surveillance System. It's unique and it can map and track alcohol and other drug, mental health, suicide and self-harm using patient care records that are coded here by Turning Point. So paramedics generate these records, they come here, we have a team of more than 40 research assistants who play an invaluable role in this particular project. NASA's undergone substantial growth, both in breadth, that is the number of states and jurisdictions that have come on board, and depth in terms of the outcomes that it measures. NAS collects more than 100 variables. These are patient-related, the demographics, location, and some outcome variables. And by that, I mean whether a patient was transported to hospital or whether police were required to co-attend. Coding this information is really important because it allows us to contextualize those harms regarding alcohol and other drug, mental health, and suicide and self-harm. The methodology underlying NAS has been published in peer-reviewed journals, and you can go and freely download these if you're interested in that. In this afternoon's session, we're going to hear about 4 novel ways that we're using NAS data. I'm going to talk about complex alcohol harms. Naomi's going to talk about opioid-related harms in New South Wales prisons. Anthony's going to talk about representers in the mental health space, and Krista's going to talk about young men's anxiety. So it's really exciting that this will draw together all of those arms of NAS. So on to alcohol. In response to the COVID-19 pandemic, governments around the world, and particularly here in Victoria, mandated lockdowns. At the time, we saw increases in alcohol purchasing, hence people in the public health sphere were worried that there'd be increases in alcohol-related harms to deal with either the pandemic or the boredom associated with the pandemic. So in our previous study, we had a look at match dates, both pre and during those pandemic lockdowns. And we found a couple of really interesting things. First of all, we found a displacement effect, and the proportion of alcohol-related harms that occurred in a home setting significantly increased. Now, this is probably not surprising since licensed venues were closed, so people were consuming their alcohol at home. Perhaps a more interesting finding was we found a time lag effect. In broad terms, alcohol-related attendances decreased at the beginning of each wave of restrictions, as you can see on the graph here, with a subsequent rebound or increases in attendances towards the end of each wave. How did we interpret this? Well, in a couple of ways. Firstly, perhaps there was a greater opportunity to socialize or drink as we came out of lockdowns, or perhaps alcohol was increasing to cope as the pandemic progressed. So where to next in order to unpack this story? I've got to say that the next question that comes to mind is really, well, what was missing from the previous paper? And the answer is complexity. Here's a snapshot of all NAS data that's coded through 2021. And what stands out to me is the high level of overlap between those four outcomes that I measured. So there's a relatively high proportion of comorbidity evident. Hence the question really became, what happened to complex alcohol-related attendances? And using a very similar methodology to the previous paper, we had a look at alcohol intoxication attendances during stage 3 and 4 lockdowns. They were the most severe compared to the 2 years match dates previously. In order to explore complexity, I used the 3 outcomes that I presented on the previous slide, the color-coded there. And the bottom of this slide shows the periods of lockdown and the number of days spent in each wave. So some results. First of all, we've got overall state results, and then we've got breakdown by metropolitan Melbourne and regional Victoria. You can see broadly here that the number of alcohol-related attendances decreased. And we found that. I'm allowed to use some numbers, right, in a data session. So there was 11% reduction in the number of alcohol-related attendances. Now here comes the but. But there was a 9% increase in the number of alcohol intoxication attendances involving suicide and self-harm, and a 37% increase in those involving comorbid mental health symptoms. We saw no change in violence. So how do we interpret this? I think a good way to do so is to go back to the beginning of my talk when I mentioned per capita consumption of alcohol remaining stable over the last couple of decades. And you can see this here with the orange line since about 1990. If we focus only on one metric though, we really lose a story. And what we start to do is lose the impact on vulnerable groups. And I can demonstrate that here on the next graph. This shows the proportion of alcohol consumed across the population. And if we add up the final 2 bars, we see that almost 50% of alcohol is consumed by the top 5% of drinkers, a vulnerable group. And in a similar vein, I think what we're seeing here is other examples of vulnerable groups that are missed if we just collapse to look at the overall number of alcohol-related attendances. So we saw, again, in our data that more complex harms increased. The largest in mental health presentation. So A next step for us is to say, well, what type of mental health presentations were they, particularly if they were anxiety related? In terms of some theoretical output here, I think it's important to ask then, why are vulnerable people accessing ambulance for emergency health care? Is there a gap in care for individuals, that is, the same individuals accessing ambulances multiple times, or is there a gap in the system, that is, a lack of alternatives? And is there a localized pattern to these data? I want to finish by thanking the team, led by Professor Dan Lubman, the NAMSU leadership team that I've listed here, and our wonderful coding team who's responsible for the data generation, our funders, particularly Ambulance Victoria and AHW, who are here with us today, and the Department of Health Victoria, who are also here. Thank you.
Thanks, Rowan, for that very complex but simple presentation of a quantitative and qualitative interpretation of the big data set. I'm sure if there is time at the end, we can get some questions fired at Rowan. But as we move on, our next presentation is Naomi Beard. She's one of the coders and works in the NAMSU team. Her presentation is Substance Use in Custodial Settings in New South Wales, a novel assessment of acute drug-related harms. Welcome, Naomi.
Thank you. Before I begin, I'm going to do my acknowledgements to start with. I'd like to acknowledge Mike McGrath as a co-author of this presentation, the NAMSU team leads, Deb, Rowan, Renee, and the 50+ staff who make up our importing, exporting and analysis teams, Dr. Harry Lay at Ambulance New South Wales, and the Australian Institute of Health and Welfare for funding, ongoing support. Okay, around the world, prison populations are known to experience higher rates of psychiatric morbidity, including depression, anxiety, suicidal behaviours, and alcohol and drug use disorders. Approximately 65,000 people cycled through the Australian prison system in 2020, a population particularly vulnerable to a raft of health issues, including communicable diseases such as hepatitis C virus, HIV, risky alcohol consumption, and illicit drug use. In a 2015 prison health survey conducted in New South Wales, 13% of incarcerated people reported having a history of alcohol dependence, 21% a history of drug dependence, and 46% reporting a reluctance to attend a prison clinic for mental health concerns, highlighting a significant treatment gap within New South Wales Correctional Services. Some harm reduction programs have been implemented inside New South Wales prisons, including screening programs for bloodborne viruses and mental health conditions upon entry, post-prison release naloxone provision programs, suicide prevention programs, and access to opioid agonist therapies whilst incarcerated. And that brings us to the rationale of our study. We have found that most studies concerning incarcerated populations examine the health of this population during prison entry and upon prison release, leaving a gap in our understanding of justice health outcomes, including overdose incidents during periods of incarceration. Therefore, the acute nature of ambulance attendance data could be a valuable tool in examining drug-related harms during periods of incarceration. Therefore, our study aims to assess the validity of using coded ambulance data in custodial settings in New South Wales and to describe the patterns of these harms related to drugs in these settings. So you've just heard a little bit about the NAS from Rowan, so I won't add too much more to his pretty thorough description. The NAS collects a range of administrative data, including ambulance billing codes. These codes vary from state to state, depending on how the jurisdiction processes and assigns payment for their ambulance services. But a couple of these examples of codes we have in our data set include correctional services, sectioning for mental health, pensioner, and sexual domestic assault codes. In our study, we identified our population of incarcerated people in New South Wales using the Administrative Billing Code Correctional Services. We only included patients aged 18 years and older with an ambulance attendance for a drug-related harm between January 2021 and October 2022. We validated our correctional services billing code through a series of steps involving mapping GPS coordinates of attendances with that billing code to a prison in New South Wales. So we used descriptive statistics to characterise our population and then use logistic regression models adjusted for gender and age to measure our drug-related outcomes against a control population with no documented justice system involvement. Please note that our results are only preliminary and that we are still actively refining our methods and findings. So here on the right of the screen is a lovely visual representation of our billing code validation. Each one of the dots displayed represents a drug-related ambulance attendance to a patient who had a correctional services billing code. And the shaded circle represents the 1 kilometre radius surrounding a New South Wales State Correctional Facility. In this example, the radius is surrounding Sydney's Long Bay Correctional Centre. So far, we have found good results to indicate that the correctional services billing code is valid in identifying incarcerated people in our New South Wales dataset, as this is further supported when you compare our map to the right, on the right to the map on the left, which has been directly lifted from Google Maps. Our incarcerated population were primarily males, aged between 25 and 34. Lower proportions of illicit substances were documented as involved in the ambulance attendances for those who are incarcerated compared with our control population. However, higher proportions of attendances where the drug or substance was unknown were documented for those who are incarcerated, with 36% of attendances fitting this description. Our logistic regression model revealed that compared with our control population, overall illicit drug-related attendances were 3 times lower in prison attendances, heroin attendances were 3 times higher in prison attendances, opioid agonist therapy attendances were 7 times higher in prison attendances, and attendances involving an unknown drug were 4 times higher in prison attendances. Although our results are yet to be finalised, we can see that epidemiological surveillance data is an invaluable tool to identifying specific public health issues among specific populations. The NAS and its correctional services billing codes have so far shown to be valid in tracking drug-related harms in New South Wales prisons. Our results revealed that within our incarcerated population, heroin and opioid agonist therapy-related harms were discernibly higher, suggesting that harm reduction programs need to be better in place to treat and assist this population. Widespread rollout of depo-buprenorphine could be one avenue to safe and effective treatment of opioid dependency whilst reducing OAT-related harms within Australian prisons. In addition to depo-buprenorphine, prison-based needle and syringe programs are a safe and effective intervention in reducing transmission of bloodborne viruses, such as hepatitis C, within prison settings and should be considered in Australian prisons. When considering where to go next, we hope to continue validating the administrative billing codes in our NAS dataset and continue surveillance on acute drug harms in New South Wales prisons using our newly validated correctional services code. And finally, in our next study, we are hoping to examine mental health and suicide and self-harm attendances within New South Wales prisons using the correctional services billing code. And that's it for me. If you have questions, come find me.
Thanks, Naomi, for an interesting presentation. This morning we were talking about looking at subpopulations. It just shows you how we can even look at specific subpopulations with big data sets by zooming down into them. So thank you very much. Our next session is by Anthony Hugh, a PhD student. He's going to be talking about revolutionising system reform in mental health, addressing gaps in the system through big data and data linkage. Welcome, Anthony.
Thank you, everyone. To give some context of my study, we know that there are increasing mental health and drug and alcohol needs both in Australia and around the world. And this has led to individuals increasingly presenting in crisis to emergency services. In Australia, there has been a 70% increase in mental health presentations to ED in the last decade. And we can see this in the media with ambulance ramping and headlines saying that people aren't receiving the care they need. We know that over 50% of mental health related presentations to emergency departments arrive via ambulance. Mental health related ambulance attendances in Victoria. What have we found so far using the ambulance data set? Approximately 75,000 individuals, 75,000 attendances each year are made for mental health or drug and alcohol or self-harm related reasons. Although only 20% of people had a repeat attendance, meaning one or more attendance in a year, they contributed to close to 50% of all the ambulance attendances. There are small proportions of individuals who disproportionately contribute to ambulance attendances. For example, there's the top 1% of individuals had 50 or more ambulance attendances each year. As to why individuals are being attended by ambulance, well, we've heard from Rowan previously that comorbidity and complexity is common, and we found this. 60% of ambulance attendances were for substance use related reasons. Around a third were for self-harm or suicide related presentations, and a third for psychiatric presentations. A third of ambulance attendances had a combination of one or more of these presentations. Why is this worth studying? Well, we know that mental health related ambulance attendances, they demand a lot of resources. On average, around 71 minutes is spent by paramedics with an individual when they attend. And of their attendances, 82% result in a transport to hospital. They get sent to emergency department. In almost 50%, 41 of these ambulance attendances, they have police co-attend as well. So you can just think about the amount of resources that's involved in mental health related ambulance attendances. 70% of these attendances occurred outside business or working hours, so in the evening or nighttime. And you can just imagine that this is when services aren't available and individuals really are in crisis and in need of support. The focus of my body of work in my PhD is looking at individuals with frequent or repeated presentations. They're better known as frequent presenters in the literature. These are individuals who have disproportionate number of presentations to acute services. They experience complex mental health and substance use related difficulties, often a combination of both. And they also experience social disadvantage, such as homelessness, unemployment, or social isolation. I am focusing on this subgroup because they really are representative of those individuals that are being let down by the system. And by having an understanding of who these individuals are and what their needs are, it can provide some insights into the barriers to accessing and receiving services from the current system. So the goals of my project are really to understand what the needs of frequent presenters are, what is continuing to drive them to continue to have repeated presentations, what other services that these individuals are being provided, or rather, what are they not being provided, and what appears to help for these individuals, what helps them stay out of, I guess, the system and not need to present in acute crisis. There's a lot of questions to be answered, but hopefully by answering some of these questions, recommendations can be provided to improve the supports and care provided to these vulnerable individuals. The methodology of my PhD project will involve data linkage, and what this will involve is using the ambulance data set, which has been previously explained quite well by Rowan, and linking in individuals who are attended by an ambulance to clinical and administrative records from emergency departments, hospital admissions, mental health episodes of care, drug and alcohol treatments and services, and homelessness services. So essentially what we're doing is we're following up an individual when they have an acute presentation, they're attended by an ambulance, and through linking into the records, we can see whether they've accessed an emergency department, whether they've been admitted to an hospital, whether they're receiving outpatient mental health or drug and alcohol care. So what else have we found so far? So looking at frequent mental health presentations, and this we've defined this as over 20 ambulance attendances in the calendar year. We found that there's increased proportions of the female sex represented in this cohort. frequent mental health presenters are more likely to present with self-harm. They're more likely to have issues with finding suitable housing or having unknown residents, and they're more likely to have police co-attend and result in the transport to hospital. Focusing on how they present, this has been a big focus of my study, because previous studies have really conceptualized frequent presenters as attendances per 1 year period. But what we have found is that most individuals actually don't continue to have ongoing frequent presentations. They present for a year, but generally the subsequent year, the next year, less than 50% will continue to have this continued pattern of frequent presentations. And we find that when they do present, it often occurs in short episodic bursts. They have maybe 1 or 2 months in a year where they have these increased presentations, but they don't sort of continue to have the frequency of presentations ongoing. So this leads to the question, well, what is driving these periods of repeated presentations, and how is the health system responding when individuals do have these presentations? So we have here an example of an individual in 2019 who had 26 ambulance attendances for mental health related reasons. And what we can do is we can see each month the number of attendances this individual is having. So the question arises, well, what's happening around here when there's sort of the slight sort of increase in attendances, and what happens here when an individual has a reduction in attendances? Some preliminary findings have found that this is looking at when someone has the index frequent presentation month, where they have their month of 5 or more presentations, and comparing this to the months preceding and months after this index presentation. And what we found was that there's increase in comorbid presentations. Individuals have increased drug and alcohol, self-harm, suicide, and psychiatric presentations during this month. I guess this begs the question is, what's driving this? What's driving this complexity? Is it that these individuals are experiencing homelessness during this period of time? Are they discharged from services and therefore don't have any support? Or do they have a relapse of their psychiatric condition? Data linkage can help provide an understanding as to what might be driving these presentations. What I have here is it's a heat map. Yeah. So you can see there's lots of sort of green. I'll explain it to you. So the shades of green represent attendances per month. These are 22 individuals, and you can track them through time from 2017 through to 2018. So there's 22 individuals, and each square represents a month of the year. The darkest green is when an individual has 5 or more presentations in a month, and the lighter shades represents less presentations. White means that they have no presentations. And what we can actually see is that individuals through time, the majority of them seem to have less periods of frequent presentations. So the question then arises, are there subgroups of individuals who continue to have frequent presentations, and what their needs are? And the use of the data linkage can help provide answers to that. And just to reiterate, the goals really are to identify who the mental health system is failing, to understand and follow their journey through the health system to get a better understanding of what their needs are, and to inform the design of more responsive mental health systems and services. There's some acknowledgements, and thank you very much.
Thanks, Anthony, on helping us understand how to get big data talk to other big data. So I think that's a very important project that will help policy and practice. So we look forward to the findings. Our last but not least is Krista Fisher. Krista will be talking about young men and anxiety presentations to ambulance services. Am I dying, or is it just anxiety? Welcome, Krista.
Thank you. Lovely, thank you. So anxiety is a significant problem for men globally, and when undiagnosed can lead to poor mental health outcomes, including depression, substance use and suicide. And in Australia, young men are half as likely to be diagnosed with an anxiety disorder relative to young women. And one reason for that is that young men can be more likely to avoid or conceal these symptoms in attempts to uphold these stereotypical norms of masculinity. So remaining fearless and strong in the face of worry and uncertainty. So what we found from past research is that rather than seeking help through mental health services, young men can present in acute psychological crises to health services with things like acute psychosomatic symptoms or increasing uncertainty around what's happening for them. And anxiety is the leading cause of men's mental health related ambulance attendances in Australia. Yet until this study, we didn't really know what these anxiety presentations actually look like, or the context in which young men are actually presenting to ambulance services. So we've heard a little bit about the NAS data so far, but really I wanted to, I guess, use this opportunity to gain valuable and novel insights into young men who may not come into contact with mental health services, but also to use qualitative methodology to amplify and bring their individual experiences to the fore by going through and evaluating the paramedic clinical care records of their attendances. So this was a 4-phase mixed method study with 2 specific aims to identify the clinical characteristics and context or typologies of these anxiety presentations. So I analysed these paramedic records through qualitative methodology in phase 1 and phase 2, developing a clinical characteristic coding framework, and then converted this to a binary data set, allowing me to undertake quantitative methodology or analyses using hierarchical cluster analysis to then identify these typologies. And so after undertaking the inclusion criteria and identifying young men who met these criteria, we had 696 young men who met these criteria and were included in the study, of which 300 were used to identify this coding framework in our pilot sample. So the first question was, what do these anxiety presentations look like? And this kind of gives a visualization of the macro phenotype of clinical characteristics in our sample. Noting here that each of these clinical characteristics are not mutually exclusive. So young men may have psychosomatic symptoms as well as having a sudden onset of these symptoms. And the most common things that we were seeing here in young men's anxiety presentations was high rates of these psychosomatic symptoms. So things like body aches, tremors, pains, even nausea, fainting, and loss of consciousness in some really severe ends of the spectrum. But there was also a lot of alcohol and drug use involved in these presentations. And young men commonly described social or situational stresses going on in their life. So this might be a relationship breakdown or work stress, unemployment, and even financial stress as well. And so through hierarchical cluster analysis, the typologies of these anxiety presentations could be identified, which essentially allows us to group individual young men together based on similarities in the types of clinical presentations that we were seeing. And I have a visualization of this on the next slide. But our first typology here was psychosomatic anxiety. And young men in, displaying this typology tended to present with psychosomatic symptoms that had occurred suddenly, but there was also a lot of, worry or uncertainty around what this was. So there was fear that it might be a cardiac related condition. Some young men describing that they were worried they might be having a heart attack, which had led them to then reach out to ambulance services. Secondly, our anxious substance use group. These anxiety presentations involved alcohol or substance use by way of either anxiety symptoms had arisen from recent substance use, or young men had attributed their substance use from increasing and unmanageable anxiety symptoms that were happening for them. And lastly, our complex anxiety group. These anxiety presentations tended to co-occur with mental health issues associated with self-harm or suicide, ideation or an attempt. And often these complex mental health issues were amplified by the situational stresses going on in the young men's life, which made engagement with mental health services increasingly challenging. And so this is a heat map visualization of these typologies, just showing how once we had separated all of the individuals into these typologies, the patterns in which the clinical codes were occurring across the young men in these typologies. So for example, all the young men in our psychosomatic anxiety group had psychosomatic symptoms coded in their presentations. And so as I start to wrap up my PhD and I guess sit back and try to think about what the next steps of research and intervention might look like, I've developed this infographic to kind of show where these intervention points for future research and clinical interventions can really go and lead to from here. But I just want to highlight too from the findings, it was clear that young men's anxiety presentations were really resource exhaustive on paramedics. So they often required a lot of resources because the symptoms that they were experiencing closely mimicked that of what we might see in a life-threatening, presentation or circumstance. But they didn't really have a lot of, resources there or procedures to manage this. They weren't often the best place to be providing care and education to young men, just because they're, so overwhelmed and already overburdened. So as I wrap up, I just want to kind of give two practical examples of what future direction might look like here. So I think what's really clear is that there's a need for better psychoeducation for young men about what men's anxiety actually looks like and the help-seeking options that are available to them. We have an example of something that's been developed in the context of men's depression. So this has actually been developed by our colleagues in Vancouver. But because research is solely focused on men's depression and not so much anxiety, we could use this to tailor it to be, upscaled for men's anxiety and potentially distributed by paramedics in attendance. So that's one thing that I'm looking at and considering. But also in terms of future research, I think as Anthony's highlighted, I think it's really important that we look at what's happening across these patient care pathways for young men, either when they are transported to hospital or when they aren't, and whether they're representing or when they then come back into contact with health services down the line, to be able to measure the impacts of anxiety on long-term psychological and physical health outcomes. And lastly, just to say a huge thank you to the team who've welcomed me here at Turning Point. Thank you.
Thanks, Krista, for an excellent presentation on another subpopulation. Thank you to all the presenters. It really has showcased the superb data set and the work that's being done here at Turning Point with the ambulance data set. And it really shows the sort of impact we can have on policy and practice and for services and for government. Congratulations, and we look forward to more positive outcomes and findings and great published research. I think we're pretty much running on time, so I don't think we'll move to questions. I think we'll move to the next stage. Okay, but before you do that, pull out your phones and vote for your most superlative presentation because that'll be the last of them.